Assalamu alaikum, good morning, where there is a good morning, and good evening, where there is a evening. And today's my topic is cerebrospinal fluid shunt infection. And actually, I am Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. A 3-month-old child with the L5 level myelomeningocele and the ventriculoperitoneal shunt present to the emergency department with 24 hours of the progressive irritability and fever, and the child had the spinal defect and closed at 2 days of the life, and the VP shunt inserted for the progressive macrocrania and the hydrocephalus at 14 days of life. He has been on a program of home entertainment and sorry home and he was a program of a home intermittent catheterization since birth and no prophylactic antibiotic. The exam demonstrate the child with the fever of the 40 degrees centigrade and the bulging fontanelle and the somnolent and irritable, and the motor examination is unchanged with the no plantar flexion in the feet but otherwise normal, and the child incision all look well healed, but the white blood cells count is elevated and the urine analysis shows positive bacteria and the WBCs. Actually, here I want to mention that what is the differential diagnosis. Definitely is suggested by this child. Actually, this child is presented with the clinical signs of an infectious illness and the clinical sign of the shunt malfunction. Though the fever itself may be causing the child's irritability and independent of the shunt malfunction, and a severely irritable child may present with the bulging fontanelle. The cause of the febrile illness may be viral or you can say there is a baby bacterial and or the respiratory, but in this case we would be worried about we can say worried about the shunt infection or the wound connection. So as well as the tap of the shunt reservoir is obtained. If you see here, I want to present a little detail to you here, like this, because of the febrile illness may be viral or the respiratory, but in this case we would be worried about the shunt infection or wound complication as well as urosepsis. So the investigation done for this patient and the child needed the cultures of the blood, urine, complete blood count, chest X-ray, as well as viral swab of the upper respiratory tract related secretion, and a full exam to look for the skin abrasion, wound complication, or other pertinent physical finding. CT scan is indicated due to the clinical sign of the increased intracranial pressure, and the tap of the shunt reservoir to obtain the cerebrospinal fluid is clearly indicated in this child, and given the presentation and relatively recent shunt surgery. So the cell amount of the CSF point toward shunt infection, even in the absence of an initially positive gram stain, the culture of the CSF will probably grow eventually. And the shunt infection are usually from skin colonization occurring at the time of surgery, such as the gram-positive cocci, are the most common. And in a child of this age, and especially one who urinary catheterization and the gram-negative and the coliform are also possible. So the child need antibiotic and some type of the shunt externalization procedure, and very few shunt infection will respond to antibiotic alone without a hardware removal. Many centers will externalize the shunt by removing the distal catheter from the abdomen and then treat until the CSF is sterile before replacing the entire system. In the event of the continued positive culture, the entire shunt system should be converted to an external ventricular drain, and some center would externalize the EVD upfront with removal of the whole shunt system, and the duration of the antibiotic treatment before re-internalization is debatable. So it averaged 10 to 14 days, but 3 consecutive negative CSF culture is a common standard. So the initial antibiotic regime need to include broad spectrum CSF penetrating coverage and the good anti-staphylococcal coverage until the organism is known. So typical initial regime would include a third generation cephalosporin with vancomycin plus or minus and aminoglycosides. So the shunt infection rate per procedure after an initial shunt placement are approximately 8 to 10% in most large studies of the shunt insertion in children, and the most shunt infection are procedure related and present within the first 6 months of the surgery. Other risk factors for the shunt related infection include wound breakdown and the CSF leaks. So the shunt infection may occur up to 25% of the time when a shunt is replaced after an initial infection. So this is the incidence of the shunt infection after an initial shunt infection. So we have to understand that the shunt infection may occur up to 25% of the time when a shunt is replaced after an initial infection. And the time frame over which there is the infection usually develop, the most shunt infection are procedure related and present with the first 6 months of the surgery, and other risk factors for the shunt related infection include wound breakdown and CSF leak. So the maneuvers have shown benefit in reducing the shunt infection. These are the great many studies attempting to demonstrate the protocol to reduce shunt infection rate, and effort to reduce the shunt infection rate have included the pre-operative antibiotic and the various procedure related technical issues such as the double gloving, short duration of the surgery timing, reduced mechanical manipulation of the hardware, and the more recent antibiotic impregnated shunt catheter. And many of these techniques include the antibiotic impregnated catheter are still the subject of some debate as their relative efficacy. So these are the actually a small we can say the video for that VP shunt infection, which is very, very important in my humble opinion. So I hope you will like it. If you like it, please subscribe, share, and so we will meet you in one more a good lecture. So thank you and see you soon.